It's good morning, everyone. Because we're recording this in the morning. Can't
Hello.
believe I'm doing this in the morning. So it's Jarvin, and that is
Hello, I'm Shar, everyone. Our partner,
yes.
are you
And
already awake?
no, wait,
I
my
bet this is too
circadian
early for
rhythm is
you.
my circadian rhythms are totally out of whack right now. I just cannot. They've been out of whack for the past few months. Anyway, welcome to the podcast. We're recording once a week, but we hope you are taking every day.
Yep. Welcome to Once
One.
Daily, everyone.
My hands, once daily. Yeah. So, okay, the usual
Your
disclaimer, of
partner.
course, this is medical advice. Obviously, please do not stop, change any of your meds without talking to your doctor and or pharmacist, right? That's
Mm-hmm.
already a given for all these episodes, but we just try to remind you from time to time.
Yep.
So, I think I really love these. It's very clear what we're going to be talking about for today.
Mm-hmm.
We're going to be doing a bit of a shift, no? Kasi the past two episodes have been all about maintenance meds, but I don't
Mm-hmm.
think today's episode is going to be for like chronic conditions, no?
Yep. Agree on that, partner. Medyo kakaiba yung drug na pag-uusapan natin. Quite popular already in the clinical setting. Do you agree, partner?
Yeah, I mean, it's like even just hearing the sound of that name, like it feels so used. No, I don't no, because I really don't have. We were talking earlier, right? Like I told you, I don't have that much
Yep.
experience in the settings that this drug should be used.
Mm-hmm.
So, but the way I seem to be seeing it, it seems to be used a lot. And from my limited experience in community, I have seen it dispensed a lot. So it's
Mm-hmm.
probably used a lot. But when you look into it, like, oh, huh, right, okay. So for this, I'll be like, I'll be clinging to your expertise on this a lot more. No?
Okay, partner. Sige.
Yeah.
Hopefully,
So
I will be able
today's
to provide
today's
expert
drug,
opinion. Yep. So today's drug is this one,
furosemide. Cheers.
furosemide.
Hmm. Isn't it weird? Like I'm taking coffee. Coffee is also a diuretic.
Yep.
Furosemide is also a diuretic.
Very
I'm
timely
gonna
sa
be pee a
topic
lot
natin.
after this. Yeah. Furosemide. Nothing notable about its name because furosemide, sulfonamide. So we'll talk about the
Mm-hmm.
allergies in that later. But generally, also sulfonamide would be like, yeah, watch
Yeah.
out for that, right? Pero
Mm-hmm.
so let's just get right into it. Furosemide, a diuretic, and on top of that, a loop diuretic. And
Yep.
just a bit of a refresher for our viewers, our listeners. What do you mean exactly when you say loop diuretic?
Oh,
In terms of like, I guess we start with the mechanism, of course. No,
yep.
bawa ka agad.
Yes.
11 in the morning.
So hopefully the listeners are also ready, no, when we are talking
Mm.
about the mechanism of action. But basically,
Juicy
di ba,
boa.
partner, when we're talking about diuretics, I think very important yung discussion kung saan sila nag-act. So when we're speaking of loop
Ay
diuretics,
talaga? Akala ko sa balat.
why in the skin, partner?
Lala. Para hindi brain. Para hindi brain yung sasabihin ko for a change, no? Oh, skin.
Ah,
Diuretic sa
skin.
skin.
Sige, why not?
Joke
Pwede
lang. Huwag niyo ako
naman.
seryosohin, please.
Uy, oo nga, disclaimer ah.
Oh, joke lang yun. Seryoso na. Sige, seryoso na. Saan ba talaga?
Okay. Going back. Yun nga, partner. Pag diuretics, di ba? Very important. I don't know if you also discussed this in your class when you do your lectures before sa
Mm.
pharmacology. Kasi nga, di ba, para
Yeah.
madali nila matandaan. So, basically, kung saang part siya ng nephron, ng kidneys natin nag-act. So,
Okay.
diuretics would have different target areas, basically.
Mm-hmm.
Parang ganun siya in context. So, pag loop, so from the name itself nga, yung loop of Henle, so
Mm-mm.
basically, in a layman's term or in the simplest term, it targets a specific co-transporter, di ba? Yung sodium, potassium, 2
Yung part,
chloride.
yung part na mukhang isaw.
Yup, yeah. Yung pag
Mm-mm.
ganon, may ascending
Mm-mm.
part and then may descending
Yeah.
part.
I don't eat
So,
that, by the way. Just like if you're hungry,
why?
just I'm getting their attention, right? You
Yes,
have
it's
to
so
bring up
early,
food
no?
every now and then. Yeah.
Yep, and it's almost lunchtime while we are recording
Mm.
this. So,
Yeah.
perfect topic, partner.
Perfect. Yeah. So the loops. All
Yep.
both the loops. Diba? It's just like a certain part of that loop, right?
Yep. So specifically, I think, partner, yung thick ascending limb ng loop of
Mm.
Henle, yun ang target
Mm.
ng loop diuretics natin. So you have the
Yeah.
ascending and then the descending part.
And I guess you have to talk, when we talk about that, you have to go about all the permeability stuff. So again, there's a lot of issue
Yeah.
always, right? I mean, it's important. I'm not a big fan, but we do recognize it's a very important foundation because if you jump right into the molecular MOA without that
Mhm.
good foundation, then it's like rock climbing but with less rocks, and everything's just going up. You don't have those scaffolding there, no? Parang
Yep.
ganun siya yung feeling.
Agree on that, partner. Kasi partner, you need to also connect it with the side effects. So if you do not know, I think
Yes.
the basic
Yes.
physiology, it's going to be hard for our viewers and listeners, di ba? And even for our students before. I think yan yung
Yep.
mga isa sa mga reminders natin na they need to understand, no? Ano ba yung sodium potassium chloride and what happens there, yon. So basically, for our viewers or listeners who are not aware yan, yun ang target ng ating loop diuretics.
Mm.
Basically, the thick ascending limb of the loop of Henle, and it inhibits that very important, that very specific co-transporter there, yung sodium potassium 2 chloride
Mm. So yung NKTI,
co-transporter.
joke, yung NKCC2. Iba yung
Yep.
NKTI. Diyan nato nag-intern yung friend ko.
Yeah, iba yon.
Mm.
Hospital yon, partner.
Pero kidney din yun. Kidney din yun.
Yep.
Yeah. So NKCC2, okay. Yeah, sodium potassium 2 chloride.
Na-connect
So
mo dun, partner, ah.
yeah. This is my morning brain. I'm sorry. Like this is much worse. I guess my students who've done me like for the 10 to 11:30 classes, they know
Mm.
this kind of me. The one that's fueled by just taho and nothing
Oh.
else. Yeah. NKCC2, so what? You're saying it blocks sodium from entering, from leaving? Because like it's a two-way street, right? Or
Yep.
again, depends on how permeable, right? That part
Yep.
is.
So the discussion actually, partner, is quite complex. But basically, what we wanted our viewers or listeners to understand is that yun nga, it's a two-way street. So, ang binablock ni loop diuretics is your sodium and
Mm.
chloride into entering the cell. Basically, blocking or minimizing the entry. And then opposite as well yung paglabas ni potassium. So, please do remember that bit kasi I think very important siya sa side effect in terms
Yeah.
of
Yeah.
side effect discussion. So, yeah.
So
Basically,
just to
that's
be
it.
sorry,
Mm.
just to be clear terminology, you say preventing from re-entering the cell. You're saying flush ihi yun.
Yup. So basically, the
Yeah.
opposite of entering is that particular component or electrolyte
Mm.
being present in the urine, in the
Right.
urinary component. So yun
Mm.
yung parang context niya in that sense. Mm-hmm.
Okay. So if they don't go back to the body, just end up in the urine. Okay.
Yep.
So
Mm-hmm.
saan si potassium dyan? So you said it blocks like sodium chloride, right?
Mm-hmm.
The absorption there. Where does potassium fit into that? And where does
Potassium.
water fit into that?
I think, partner, I'm not sure if you're familiar with this acronym. Ginagamit ko kasi ito sa discussion ko para
Oh, okay. Acronyms. Yeah. I love my acronyms, especially if they're really good. Go. Hit me.
yung yung famous acronym when we're discussing diuretics that
Mm-mm.
students should never forget. Kasi nga,
Ano
palagi
yan?
daw
Ano yan?
lumalabas sa boards.
Ew.
um,
Ports. Pero basta, I mean, as long as it's accurate, fine. I don't mind, right?
yeah, they say that basically not an acronym pala, partner, but parang what do you call that? A phrase, a catchy phrase that they say where sodium goes, water follows. Do you agree on that, partner?
Yeah.
Mm-hmm.
Definitely. Yeah, I love that too. It's very,
Mm-hmm.
So, I mean, I guess, you piss is kind of 90 something% water, right? So,
Yep.
kind of makes, I mean, yeah, it's kind of easier to remember then. So, with sodium is
Mm-mm.
like, whoosh, isama si water. I, I,
Yep.
I cannot, I cannot English in the morning. I'm so sorry. But yeah, that makes sense. So that means sodium chloride, water by
Together, yep.
and what about like potassium?
So potassium generally is included, no, in this particular transporter. So papasok basically, or
Mm-mm.
sodium and chloride and water will re-enter in normal
Mm-mm.
physiology, and then sodium will be part of the urine's component.
Normally, kapag
Yeah,
walang diuretic.
normally. Yep.
Mm-mm.
That's a normal physiology for this particular co-transporter. But
Mm-mm.
if you have the loop diuretics, then yun nga sabi natin partner, the loop will
Mm-mm.
try to prevent the normal function of this co-transporter or of this transporter. So basically, it will try to block yung re-entry. So it will try to minimize the re-entry of your sodium, chloride, and then the opposite for potassium as well. So instead of potassium going to our urine, be a component, so opposite siya, it will try to re-enter again the cell. Mhm.
Can you believe we put students through all of this, but when we get to antidepressants, all we say is chemical imbalance? That really is so unfair, no?
Uy, partner, I
Like,
saw your post about
yeah, yeah.
WHO.
No, yeah, sorry. It's just
Mm.
like this has been all the rage on Twitter for a few weeks. It's like we go
Yep.
all so detailed about this mechanism. When we get to psych, it's always just chemical imbalance. Like, are you serious? But yeah,
I,
but you did say it yourself. It's important we discuss the mechanism because when we get to the
mhm.
side effects, it will come into play,
Yep.
right?
Yeah, agree
Yeah.
on that.
Mm-mm.
So therefore, dapat pantay-pantay lang kung magdi-discuss ng
Yes,
mechanism of
amen.
action.
Dapat lahat mahirap kasi mahirap talaga yung tikol. Para
Yeah, mahirap
fair.
talaga. True. Agree.
Yes, yes. Yeah, but did you hear about that other mechanism? I mean, I know it's in the
Mm.
textbook, but it doesn't get a lot of spotlight. No.
Mhm.
Cox, apparently.
Mm.
Like Cox of the NSAID fame. Cyclooxygenase
Oh.
enzyme. Yeah, yeah. So apparently, independent of all of that electrolyte shiz,
Mhm.
furosemide can promote COX expression, meaning more COX. I'm gonna stop whoever's listening. Yeah, I know what you're thinking. Stop it. Bonk. But anyway, so promoting COX expression, right?
Mhm.
Meaning more COX, more prostaglandins. Apparently, that's more
Mhm.
venodilation, and it's apparently helpful for what it does later on.
Ooh,
Vasodilation for both the lungs and the kidneys.
So it's not a
Apparently.
targeted or specific partner. Kasi honestly I haven't heard that much about that aspect. So
Oh yeah,
when you
yeah,
say
same.
COX, it's not that specific, I think. Tama ba,
Cox
partner?
2.
Oh,
Cox
it's
2
specific for
apparently.
COX too. Yeah.
Cox 2. Yeah, my
Mm.
bad. I forgot to specify. So specifically they're looking at like prostaglandin
Mm.
E2.
Oh,
And
okay.
apparently not only does it block it also helps a bit apparently because
Mhm.
prostaglandins they have a role right in the whole electrolyte balance sa kidneys din apparently,
Yep.
right?
Mhm.
So it can also block a bit of the sodium chloride reabsorption, but at the same time there's also a bit of vasodilation in the kidneys. So when you dilate the blood vessel, a lot more blood can flow because blood flow, right? That's kind of the signal. Sorry, I'm going to RAS territory. I really wanted to talk about RAS last time because RAS
Sige,
is kind
go,
of fun.
partner.
Yeah, yeah. Because like, but for one part of our body that regulates blood pressure, it's like um renin, angiotensin, aldosterone system, and
Yeah.
the spark to start that whole system, that absolutely horrid system that we no longer need at this moment. Okay, some people might need it. Fine. Is is yung low blood flow. It's like
Yep.
when you're
It's a
dehydrated,
trigger.
ganyan. Yeah, yeah. So apparently
Agree.
the vasodilation that increases the renal blood flow can kind of stop that trigger from happening because you're increasing the blood flow there. So your body doesn't think that your blood is running low. Parang
Yep.
ganon.
Mhm.
So no RAS, none of the bad stuff, supposedly.
Mhm.
Lots of bad stuff when you're
Bad
not
stuff.
living in the when you're bad stuff, asterisk when you're not living in the desert. If you're living in the desert, you need this. If you're not living in the desert,
You
then
don't
maybe
need it.
not as much. Yeah. Yeah. But
Okay.
yeah, yeah, that'll come in. Those all of that. Wait, tumakit yung ulo ko slight. Buti na lang may naman ko ng kape. Coffee is good for tension headaches.
Oh, really?
Lower risk of Parkinson's. But if I have anxiety in general, so that's going to make it
Mhm.
worse. Trade off na lang. So yeah, that'll come in
Mhm.
handy later, I guess. I need my brain needs to rest a bit. Okay, speaking of what it's used for,
Mhm.
when I was in undergrad, I had an idea that because it makes you pee a lot. That's what the diuretic is, right? Net result, you pee a lot.
Mhm.
Pee, that's mostly water. The more water in your body, like the higher your blood pressure is. So I imagine,
Yep.
okay, the more you pee, wouldn't that mean the lower your blood pressure is? So I always thought furosemide is used for hypertension. Is it an antihypertensive, quote unquote?
Technically, partner, theoretically speaking, when I discuss antihypertensives, diuretics is included in the discussion. Just
Really?
just because theoretically the net effect that it produces, including I think we're going to discuss this later, but yung net effect kasi ng diuretics and even parang the side effect that these group of medications, not only for loop just to give context. So
Mm-mm.
it's included in the discussion of antihypertensive because of that specific you mentioned RAAS kanina, partner, right? So
Yeah. Mm-mm.
some of our listeners already na may background about RAAS, they know that the diuretics, when they act, they can have a final effect or a final net effect of hypotension. You've mentioned this as well earlier,
Yeah,
partner.
yeah. We probably need to pause because okay, we'll give you 5 seconds because we went from electrolytes to renal
Electrolytes.
physiology to
Yeah, we're
RAS. It's
jumping.
another thing altogether. So you breathe kayo, inhale,
Yep.
hold, and exhale.
Mhm.
Yeah, then breathing into the mic, arms breathing.
Mas
Okay, sige,
ma-feel nila.
sige. Yeah. So net effect, lower blood pressure. That's for all. Okay.
Yep.
Suppose a theory. I don't like theory. What actually happens? Lay it down to me fully.
Mhm. So you said, partner, we tried to connect it earlier with the
Mm-mm.
transporter when we were mentioning the
Yeah.
mechanism of action as an overview. So we said
Yeah.
na si loop diuretics, basically they block this transporter, so your sodium and your chloride will not be able to enter. We said that where
Yeah.
sodium goes, water follows. So you said
Yeah.
earlier, technically when you have a lower water content, lower fluid volume in the body,
Mm-mm.
when you diurease, 'di ba? Yun ang magiging net effect niya.
Wow,
When you
social
diurease,
diaries. We don't do piss. We don't do pee. We don't do ihi. We do
oh sige, diurease.
diaries. Fine, diaries.
Yeah, when you diurease, technically um yun nga, you decrease the fluid content, the fluid volume
Mm.
of your body. And we
Mm.
know, partner, in that same context, we when you decrease this, it has an effect, direct effect sa blood pressure. 'Di ba, when we are discussing hypertension, I don't know if we mentioned this in episode 1, but for our participants or listeners, maybe you can
Man,
quickly
that was
go
two
over.
years ago. I don't remember.
Me
I
too, I don't
remember.
remember.
Yeah.
It was so long ago. But
Okay,
I'm
okay,
not
you were
sure if
saying.
I mentioned that, or if we were able to mention that yun nga, cardiac output is an important factor or criteria in the regulation of blood pressure. So in that sense, partner, it can be considered an antihypertensive because it affects the fluid volume. But again, I wanted to emphasize that yung cardiac output, it's not the only important criteria with blood pressure
Right.
regulation. Yep. So it's
Oh
not
no, you're
the
doing the
sole.
formula. You need to pause
Yeah.
again because it's a third concept. You know, it took me like after grad, no, to be fair, okay.
Mhm.
Para di kayo ma-discourage. It took me until after graduation before ko siya na-master. Hindi ko siya na-gets even after the boards.
Partner, kasi it's hard. Even
Yeah.
honestly, the professor is very hard to like make sense of this very
Ala, sino
complex
yan? Jo,
formula.
issue. Ala,
Hoy,
issue. Ako pala yun,
let's
no?
not name drop. Charot.
Okay, tapos.
But it's very hard to
Yeah,
make sense
yeah.
of
I think
the
even if the prof is good,
regulation.
mahirap talaga siya.
Yeah,
Mahirap talaga siya.
So it's very complex, yun nga sabi nga ng student, pag cardiovascular daw ang discussion, "Ma'am, why you do this to us? It's so hard." But I always tell them that this formula is very important. If you do not understand this, then GG. 'Di
True,
ba? So it's
true.
very important in the
I had to use
discussion.
my plushies to like illustrate cardiac output and stroke volume, which is a
Yep.
fun challenge in itself. So
Mhm.
yeah, I guess review because if we talked about that din naman in detail, we're
Yep.
gonna go over.
Partner, baka
Okay.
maabot na yung podcast natin na more than 1 hour.
Oo nga, parang every episode humahaba no? Pero,
Dumadagdag ng
wait.
dumadagdag.
Yeah. Pero okay, theoretically it affects it. But in actuality, sige, let's cut to the chase. In actuality,
Mhm.
Does it really lower blood pressure long term?
Ah, long term, I would have to say no.
Yeah. Kasi chronic
Kasi,
diba? Hypertension is a chronic
yep.
non-communicable disease. So it's like
Mm-hmm.
medyo maintenance.
Yep.
Kasi
Mm-hmm.
antihypertensive, you're talking, unless it's an emergency, we're talking maintenance meds here.
Mm-hmm.
So the question is, can furosemide, if it were to be made a maintenance med, would it lower blood pressure? And so you're
It,
saying no.
yep. Mm-hmm. Yun nga.
And sorry, the more important question, because when you say hypertension, but we said in episode 1, we don't care about the blood pressure. We care about, will it stop your blood pressure from doing damage to your organs? So the
Yep.
question is,
Complications.
will it stop complications
Mm, um,
in like just uncomplicated hypertension?
per
Will
se.
it protect against damage against the organs? Right? And that's what we're trying to protect
Ooh.
against.
Kasi partner,
Since it's
when
a,
you're yeah, when we're talking about hypertension, usually for patients, it's not only hypertension eh. We're targeting. Usually when I see furosemide in a clinical sense, you do not
mm,
just give it mainly for okay, this is an antihypertensive drug, this is the first line you give it. No, it's not used in that way eh. The
okay.
clinicians give it because usually if a patient has hypertension, meron na siyang other comorbidities. Ang daming sakit, ang super
Uh,
daming other
yep. I've seen
complications.
I've
Mhm.
seen a few like that, but I'm sure you've seen more than what I've seen for sure.
Yep, before in the clinical setting, yes, partner. I've been handling geriatric patients and with hypertension. They do not just have hypertension, partner, sadly. So in that sense, furosemide loop diuretics is not mainly used as an antihypertensive medication. It's
Okay.
used in that context because your patients have other important, clinically important comorbidities.
Yeah. So in this
Mhm.
case, hypertension takes a backseat to whatever else is like
Yep, yep.
the problem furosemide can actually help with. And the problems that
Mhm.
furosemide can actually help with. So I guess you're saying since it's not good for maintenance, generally
Mhm.
when you talk about the rational use, we expect this to be used for shorter periods of time. Unlike
Mhm.
say clopidogrel, you'd use it for a bit longer, no?
Yep. Mhm. Agree on that, partner. Yun, I think ito yung most common misconception siguro din if we're going to rank the misconceptions in
Okay.
furosemide in loop diuretics. I
Uh,
think I don't know, some clinicians, some healthcare professionals might be thinking that this drug is a maintenance therapy, but actually it's not. So we want to make that one clear, I guess. But yun nga, hindi siya maintenance therapy for hypertension per se. But yeah, for the other important
yeah.
clinically diagnosed comorbidities of our patients in that
And
sense.
those would be
Okay, those would be basically when I see patients on furosemide. Other than hypertension, I see patients who have heart failure being given
mm,
with furosemide. What else? Usually patients na may kidney disease like
mm,
CKD and AKI. Or ito
okay.
na naman tayo sa acronym, your acute kidney injury. So yan, CKD is
Or
chronic kidney disease.
yeah, yeah. And also edema, right, in general.
Yep, edema in general. I agree on that, partner.
Right,
Mm-mm.
right. Well, even in those cases, like for example, heart failure, you have that ABCD memory aid, right? So you have
Yep,
ACEs, RNAs, etc., beta blockers,
beta
after
blockers.
stabilization, then so on, so on.
Mm-hmm.
Furosemide normally isn't on that list of like the guideline directed medical treatment, right? Usually
Mm-hmm.
we see it like in like the decompensation cases,
Mm-hmm. Yeah, for
right?
decompensated. Yep,
Usually.
agree.
I assume that uh for the edema, like pulmonary edema, that's where the COX part can come in really handy, I
Mm-hmm.
guess. Because promotion of COX-2, that's like venodilation, and apparently even before the diuresis begins, patients can already feel like their difficulty of breathing is just going away because of
Mm-hmm.
the dilation induced by the furosemide. That's also pretty cool.
Yep.
Yeah. But another thing, since we're talking about misconception, another thing I also want to kind of sneak in is it's not good for all edema, apparently.
Mm-hmm.
But like one common example, have you ever come across amlodipine induced edema?
Oh, yes.
edema from
Oo.
CCBs, right? That it
Yup.
looks like
Mhm.
classical edema, right? But
Mhm.
apparently, you're not supposed to be using loop diuretics for that. They don't do
Yeah.
anything for that.
Yep.
You're supposed to be
Mhm.
using thiazides.
Yep. Mhm. Agree on
Yeah.
that one, partner. Usually, I don't see furosemide clinically being used to treat the edema induced by amlodipine.
Yeah,
Mhm.
although given that there have been entire threads on this, I assume some people think it can be. So I guess you really
Yep.
wanna um yeah. So the
Kasi
lesson there is
partner,
not all edemas are equal.
yep. Oh, kasi partner, you will often see this for those listeners in the hospital, practicing in the hospital. They will often see this medication, lalo na if yun nga, madaming comorbidities yung patients nyo. Paulit-ulit siyang, you will see this in the chart. I think not one day will pass by that you won't see this medication. Kaya sabi ko
Mm.
kanina, it's quite popular kasi this medication is repeatedly ordered in the charts. But yun lang, we wanted to remind our listeners that um, sometimes kasi baka nakakalimutan yung proper use of furosemide in some instances. So, I have to agree on that one, partner. Yung edema is not all equal. So, it depends. So, kailangan alam natin what causes the edema and what type of edema is that. So, yeah.
Yup.
Mhm.
Yep. And you say to use a lot in the hospital. I hear. I don't know if our listeners or viewers here they follow Dr. Glaucom Flecken. Every time, every time I
I love him.
yeah, every time I watch his TikToks on cardio when he plays the cardiologist and nephrologist, 90% of the time furosemide is always mentioned.
Mhm.
And so
True.
like I don't know if you come across like in your practice like this is not to hit on them because
Yep.
I mean when Dr. Glaucom
Disclaimer
Flecken makes
again.
his joke, I think cardios and nephros are in agreement that it's always I mean it's a lighthearted banter that it's often a point of
Mhm.
contention in actual practice. I've never seen it, so I'm just simply observe. This is simply my observation. Like when cardios and nephros react to those kinds of videos, like it seems to resonate with them. Have you seen this like in actual practice?
What partner? Nagbabanter
Like
yung cardio
the
and nephro?
discuss sige fine extensive discussions on furosemide between cardios and nephros whenever it appears in the chart.
Honestly, partner, I haven't seen them banter or extensively discuss. Like what
Okay.
Dr. G is portraying in his TikToks, no? Hindi ko pa siya nakita ng ganong discussion. But
Right.
when you have a cardio and nephro on board, you have to alert them even though if, for example, cardio ang nag-prescribe. Because it
Yeah.
affects if for example, ang patient mo may kidney impairment, you have to alert the nephrologist as
Yeah.
well, 'di ba?
Yeah.
So,
Yeah.
you have to
Yeah.
alert them both. So, I think yun yun yung need na 'wag kalimutan. You have
No,
to make sure they know what you're going to adjust sa medication for
yeah, no,
specifically for
that's one thing I wish I had more experience on because
mhm,
oftentimes my interactions with the healthcare team is like one-on-one. So
mhm,
sometimes like a general medicine practitioner will come to me and ask about the psych med. So it becomes a more liaison consultation
okay.
informally, or it's
Mhm,
like one-on-one with the psychs. But I think the multidisciplinary team experiences it would be nice to have, I feel. No.
mhm.
Uh but I think, what they often end up talking about is dosing, right? One group thinks that furosemide is often underdosed in patients. Is that because of the
Mhm.
bioavailability?
So, if we're going to take a look at references, they say that the duration of furosemide is about oral to a partner. So, orally,
Mm.
around 6 to 8 hours daw. It can go as long as 6 to 8 hours.
Mm.
So, I think yung 6 to 8 hours has an important implication in when we are discussing dosing or
Yeah.
if we're going to try to adjust the dosing of patients, for example, when you're dealing with renally impaired patients, that's very important. But,
Uh-huh.
yun nga partner, I think we were discussing this earlier. You have, an input on this one with regards dun
Yeah.
sa 6 hours, dosing or duration pala rather of
Yeah.
furosemide.
Oh yeah. So I think that's one popular idea whenever you say I won't say the brand name.
Mhm,
I don't like saying brand names, but
mhm,
supposedly the innovator brand comes from the idea that it lasts 6 hours. Apparently not. It lasts less than
hmm,
that. The one that lasts 6 hours is torsemide, 6 to 8.
hmm.
Which is different from half life, by the way. You're talking about
Yep.
duration. So lasting less than 6 hours. Even besides how long it lasts, apparently how its rate of absorption can range from like orally at least can range
Yep,
from like
orally.
10 to 100%
Mm-hmm.
din.
Very
So that's kind
variable,
of
no,
like
partner.
yeah, kind of really mind-boggling. I guess in the hospital I assume it's not always given orally, right?
Mm-hmm.
Because so you see it IV a lot more
Yep.
in the hospital, is that right?
Mm-hmm.
What
IV
are
a
the
lot
common
more.
doses? Sige, what are the common doses? I'm also trying to
Mm-hmm.
figure out what's the underdosing issue here. What are the common doses you
Mm,
see if furosemide?
usually they start 20. That's the usual dose that I see. 20
Yeah.
milligrams once or
Uh-huh.
twice. They can ramp that up to 40 milligrams once or twice. So usually ganun, partner ko siya nakikita. 20, 40. Ganyan mo lang siya makakita sa chart.
Pero
So,
like total like how many times a day is that?
oh, usually I see it once or twice in a
Oh,
day.
okay. Okay.
20, 40 once, twice.
I'm starting to see where the dosing discussions might come from because I just
Mm-hmm.
went back to the monograph. I'm looking at it here.
Okay.
Maximum dose, effective dose varies by population. Higher than usual doses may be required for patients with nephrotic syndrome or renal failure. The
Mm-hmm.
maximum recommended total dose is 600 milligrams per day.
Oh, wow.
Wait, I need to I
To
knew the dose
internalize the
could go
600 milligrams.
higher. No, I knew the dose could go higher. I didn't know how high it could go. I mean, that's the highest, kumbaga. But I
Yep,
assume not
partner.
all doses go that high.
Mm-hmm.
But that also implies that the ceiling's actually higher than we realize it is.
Partner, I think yung 600 milligrams total,
Total,
yung,
yeah, total. That's why I
yep,
asked how many times a day.
they can give that with CKD patients, but I haven't personally seen it being given clinically that high, na umaabot ng 600 milligrams
What's the highest? Sige, what's the
in a
highest you've
day.
seen? What's the highest you've seen in a day?
Siguro around nasa 100 to 200. Parang
Okay. Okay na yeah,
that
no,
range.
that's
Mm.
something more na pero basically, if you think about, we usually see 20 to 40 and
Mhm.
you have seen doses up to 200 used,
Mhm.
I'm not saying you should be ramping it up because again, I have no experience in that. Please don't take my word for it, right? So it's more of like the idea that, if you talk to the people who usually use those higher doses, it probably implies that the ceiling can be higher in consultation again with the people who usually manage those higher doses.
Yep. Mhm.
So and I guess that's really where the question comes from. Like, I don't know. One group may argue that that's too high. The other group may like, but it's not
Say
working at
it's yep.
all.
Mhm.
No, if you use it too low.
Pero I think, partner, in that discussion, I wanna bring back the term that you used earlier, yung maximum effective dose. I think yun ang
Okay.
very important na kailangan tandaan ng listeners natin or viewers natin when we're discussing dosing of furosemide particularly.
Yeah.
Kasi nga, in this discussion, in this debate of whether 600 is high or whether 40 is still low or underdose.
Yeah. Okay. Okay. Sige, we're
Yeah, 'di ba?
exaggerating, but okay. Yeah.
Yep. So, I think yun yung kailangan nilang tandaan that, the maximum, effective dose really varies for certain individuals. So, you cannot like, if the doctor prescribes 40 milligrams 3 times a day, let's say like that, for a patient with CKD, it's not the 100% accurate dose or hindi na yun yung parang, "Okay, this is the only dose that we can give for this particular patient population." Kasi yun nga,
Right.
it
Right.
really varies on the patient's condition. Usually with CKD, sabi natin with hypertension, you do not only have hypertension. For CKD, it's the same. You do not only have CKD. So, binabalance din yan ng mga prescribers natin. Parang like,
Right.
what really is okay for this patient? No, if I give 83 times a day, 43 times a day. So, I think yun yung gusto kong emphasize that
Yeah. Yeah.
it varies per
Mm.
patient. So, hindi porket sinabi ng monograph, ng lexicon, ng kung anong guidelines that we are referring, you do not just, okay, you do not like put it in your mind, okay, 40 TID is the best way for CKD. So, it's not like that.
Yeah,
So,
yeah.
yun
So
lang.
I think this is where the collaboration can really shine, no? Kasi for
Mhm.
these very complex cases talaga, I don't like natatakot akong i-handle by myself. Like I really just want to ask people questions like, what do you think? What do you think? Right. So
Mhm.
even though I don't have any experience, if I were to like go into it like on day one, I'm gonna talk to like the people of the team. It's like, yeah, right. So I think that's really where like having teammates can really shine through. Like
Yeah.
so I guess a healthy amount of um banter on that is good na rin.
Yeah.
No. So I imagine it can these are how we can prevent both underdosing and
And
overdosing at the same
overdosing.
time. Yeah, because
Mm-hmm.
I imagine both problems can happen din naman.
Agree, partner.
Ah, yeah. That aside, what are the usual complications that we have
Ooh,
to like watch out for with furosemide? Side effect territory, our favorite part.
okay.
One of
Yeah.
our favorite parts, I think. Yeah.
Yun nga partner, sabi natin we are trying to connect, 'di ba, the mechanism of action with the side effect, with the complication of your medication. So we've
Yeah.
mentioned blocking sodium potassium 2 chloride transporter earlier.
Mm-hmm.
So basically, if you block that, you prevent sodium from re-entering the cell.
Mm.
So if you prevent sodium from re-entering the cell, then the side effect of one of the major side effects of furosemide and loop diuretics per se is hyponatremia, because you do not
Mm.
have sodium, or you will have low sodium in your blood, yung level
Right.
ng sodium in the blood. Yep. So
Right.
you can have that as well. So more on, I think, generally partner, when I remembered when I was discussing this, yung diuretics. Usually kasi electrolyte abnormalities, electrolyte
Yep.
complications talaga yung, yeah, when you discuss this, you cannot go and say goodbye everyone without discussing electrolyte abnormalities. Pero
Yeah.
partner, bawal to
Kudos to
skip.
Nephros for dealing with this every day.
Yup. Yeah. Galing nila
Okay,
when they're
but
trying to
but
adjust.
I think here's a point of confusion that might arise because you said wherever sodium goes, water follows. So
Mhm.
technically, yeah, the sodium is going down, but
Mhm.
so is the water, right?
Yeah.
So
Mhm.
if you look at it like at first glance, shouldn't it be like lower sodium, yes, but also lower water? So shouldn't they balance each other out?
Partner, I think in this discussion din, papasok din yung hypovolemia. If you're going to
Mm.
like, syempre diuresis ang, yun nga, yung net effect ng diuretics, di ba, from the name itself. So you can expect that side effect per se sa diuretics in general, hypovolemia,
Mm.
because yun nga, sabi natin, where sodium goes, water follows. So basically, sodium will pull the water out of the body, blah, 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 to adjust the blood pressure. So
Mm.
you can expect that side effect, partner, yung hypovolemia, in that sense, and
And
hypotension in that
right.
sense. Mm-hmm.
Right. But at the same time, we did mention that hypovolemia, a reduction
Mm-hmm.
in blood volume, can also trigger RAS.
Yup.
Right. So
Mm-hmm.
RAS means more ADH. More
Mm.
ADH, more antidiuretic hormone
Mm-hmm.
means no diuresis,
Mm-hmm.
meaning water
Uh,
stays in the body, meaning sodium is diluted. So I guess that makes sense. Na hyponatremia still is a thing and not
mm-hmm.
hyper. No.
Yep. Mm-mm. Agree on that, partner.
Is that in my head?
It's so hard.
Sorry.
Ang hirap pag-usapan ng electrolyte imbalances,
Yeah,
partner,
because you
without
have to like integrate all three of those things. You have to do RAS, you have to do the
mm,
CO times SV, you have
yep.
to do the electrolyte thing. You have to do them, you have to juggle them all at the same time.
Mm-hmm.
And
Kaya,
like I can feel a literal headache at the back of my head here just thinking
tension
about all
headache.
of them. Yeah, pero I guess if you really want to understand, I guess it's really important to master all of them, no? Kasi
Mm-hmm.
otherwise,
Agree.
you'll think na, ay, ihi naman eh. So, mababalance out yung hyponatremia with the hypovolemia, di ba?
Yep, yep. Mm-hmm.
Other electrolytes din ba?
Mind-boggling.
Yeah, other electrolytes din ba?
Yep, partner. So, from the name ng target niyang transporter, di na tayo lalayo sa
Mm.
discussion. So, yung
Mm.
potassium, di ba you were asking of
Mm.
potassium earlier. So, one
Mm.
very important side effect of furosemide and loop diuretics as a class is hypokalemia, that is usually asked
Ah.
in the boards.
I mean, okay, I hate boards. I hate board focused questions. I hate them so much. But if they're still up to date naman, then fine,
Yep.
I'll let it slip, right? As long as it's relevant, as long as it's not about Maui's, then I'm fine.
Oh no, the Mawis. That's on another separate topic
No, that's
altogether.
the general topic of meds not in the Philippines. We waste our time on. We waste so much of our time on those.
Yep,
Yeah,
partner, agree.
but yeah. So basically, electrolyte imbalances,
Mm-hmm.
reductions in sodium, potassium, magnesium too. Is the
Mm-hmm.
thing.
Yep. Mm-hmm. But not that
And
much on magnesium, partner. Usually, yan talaga, hypokalemia, yan ang binabantayan
yeah.
with loop diuretics.
Yeah. And I have a similar question. So I'm sorry I'm throwing all the questions to you. But I promise bawi tayo when we get to something CNS related. Pero
Yeah, ako naman
um
magtatanong sa'yo, partner.
yes, I love that. No, yeah, that's fine. Especially if
Mm.
we both get to ask questions. The Kloppy Dogrel, we talked about the eye bleeding, the bleeding, right? What to watch
Yeah,
out
yun
for.
naman. Yep.
Um, I mean, you can monitor electrolytes by like lab tests. I'm sure you do a lot of lab tests,
Mm-hmm.
right? The blood tests to check for sodium, potassium, etc. So you can monitor
Mm-hmm.
those. Clinically, like what can clue you in to the idea that these side effects might be happening? Of course, it's
Mm.
assumed you're doing monitoring, right? It's assumed you're doing monitoring, but
Mm-hmm.
just to supplement the monitoring, what are like other clinical signs that? Because this is also something I also try to I also try to watch out for with SSRIs because like
Mm-hmm.
there are segments that can cause hyponatremia. So
Mm-hmm.
so what are things you can watch out for, like in regards to like possible electrolyte deficiencies?
Siguro yung in terms of physical, if you're talking about, partner, physical manifestations,
Mm-mm.
for hypo-K, yan kasi usually ang mina-monitor. So for hypokalemia, usually kasi potassium associated yan with muscle contraction. So
Mm-mm.
if you have hypokalemia, and lalo na geriatric ang patient natin,
Mm-mm.
they really watch out for the muscle tone, yung muscle weakness.
Okay.
So, I think though I'm not that familiar with the actual parang physical tests or exams being done to like check for this one, but I think this is as well as if we're going to endorse this with the nurses.
Mm.
Sasabihin natin, for example, na may diuretics sa patient, may furosemide, blah, 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 possible side effect, hypokalemia. I think they do this, they can check for this routine during
Yeah,
their
yeah.
physical exam when they meet the patient.
Mm-mm.
So yeah, I think they do that. Yung mga
And
ganong
then with
manifestations.
yeah, and with the sodium, apparently there are like mental status changes. Of course,
Mhm.
hyponatremia is less likely with SSRIs. So have you seen these mental status changes with like diuretics, with furosemide, for instance, when they get
Partner,
hyponatremia?
kasi it's hard to pinpoint if it's really from a particular medication or if it's the manifestation of your
Mm-mm.
patient's disease
Mm-mm.
progressing, 'di ba? Like, for
Mm-mm.
example, I usually see this with geriatric patients. Sa
Mm-mm.
geria, you expect cognitive decline because of their age and because of their disease. So
And
it's hard.
delirium.
Yup, and delirium. So it's hard
Mm-mm.
to like say to the doctor na, "Hey doc, my patient is having cognitive decline. This is because of furosemide. Remove furosemide."
Mm. Okay, I'm gonna quote you on that and put it on a frame. And every
Yeah.
time someone gives me a list of 10 meds and blames
Mhm.
the psych med, I'm going to get that frame and bonk them on the head with it. Okay,
Monk, monk,
because
monk.
you made a very good point. This is
Mhm.
not just with with just specific meds, but like in
Mhm.
general,
Yup,
right? When
in
you have like a
general.
list of 10, 20 meds and
Mhm.
several comorbidities, and you blame that one particular med without actually checking the
Mhm.
context, the timeline, the
Yup.
history, the
Mhm.
picture. It's like, really? And then the worst is like you have escitalopram and freaking furosemide on the same list, and you
Mhm.
blame the escitalopram for the hyponatremia. I'm like, did you
So
check
so
first? Did you check
yup.
first?
Why you
Please
only
check.
blaming escitalopram?
Yeah. Dr. Shaban, she calls this a psychotropic diagnosis syndrome.
Mhm.
But like you've clearly illustrated, it's not just in the context of psych meds. Like in general, you really do have to check first, no? So
Yeah.
I like what you said. I love it so much. I like to frame it and just bonk people on the head when they blame psych meds. Check first, please.
Very true part. I think,
See, yeah,
very
because
important point yun kasi nakakalimutan ng minsan even the clinicians, even those practicing in the clinical setting, they kind of forget that that context. Kasi nga minsan naka-focus tayo masyado sa side effect ng medication. Now, when you know this particular side effect, automatically it will be evident in your patient. No, it's not the case 100%. Yun din yung palagi ko sinasabi with my students. It's not the case. Even if the textbook says, even if the guideline says this will manifest, it will not 100% manifest for our patient. So yun yung palagi yung tatandaan.
Right,
Mhm.
right. So if the insert says, I will get struck by lightning while taking paracetamol, it will
Yep.
definitely 100% happen. No, I'm just kidding. It's just opposite of what you said. Yeah, but yeah, that's true. Yeah,
Mhm.
definitely. Right. So to cap it all off,
Mhm.
interactions, anything to worry about there. So I assume with diuretics,
Mm.
um, anything affecting the kidneys. Is that right?
Yep. When we're talking about diuretics per se, I think partner, sabi natin kanina, you discussed yung NSAIDs na part.
Yeah.
So they have a significant interaction with non-steroidal anti-inflammatory medications per se.
Mm.
So some
Yeah,
references
makes sense.
categorize this with a risk rating of D. So
Mm.
for Lexicomp, they say this is D, meaning consider therapy modification.
Right.
So ayun lang din partner, if our practitioners would see this particular risk rating, kasi not all naman would warrant really a therapy modification. So yun lang din,
Right.
another point to consider is that they really have to check yung current condition ni patient before they are able to recommend like dose change or tanggalin 'tong medication na 'to sa list ng patient. So yun,
Yep. Yep.
in terms of
So what
yep.
happens, right? What happens when you combine the two exactly?
Yep. So when you have an NSAID, um, and a loop diuretic in general, so as this is a class drug-drug interaction.
Mm.
It's so basically it has an effect dun sa what do you call this, a nephrotoxic yung kidney function, yung toxicity ng kidneys. So it has
Mm.
that specific effect. So Lexicom actually says your NSAIDs may diminish the effect of your diuretics and your loop diuretics
Oh.
can enhance the nephrotoxic effect of your NSAID.
Ah,
So may
so
ganong
two.
clause. Yep. So
Yeah.
efficacy and the toxicity, the
Right.
complication.
Yeah, and that okay. Because I was asking about that. We had to talk about that earlier, right? So I was
Mhm, yep.
wondering because usually
Mhm,
you hear about like the kidney problems. Yeah, they both affect the kidneys. So if you add that up, like additional, you watch the kidney more. But at the same time, because furosemide promotes COX expression for
mhm,
vasodilation, and NSAIDs block COX.
mhm.
So if furosemide works to promoting COX expression, then NSAIDs might actually slow down how it or impair
The
how it
loop
works. And
diuretics.
okay, so it's nice to see that it's actually a clinical. It's been observed clinically that it can impair efficacy. I thought it was just theoretical kasi. Syempre,
Mm, yep.
before we do head canons, we just gotta check if it's actually a thing in practice, no?
Mhm, yep. Watch. I think partner watch out to if we endorse this with the with the prescribers and the nurses. But if in that context na hindi naman kailangan ni patient ng additional monitoring, they don't usually request addition kasi it's an additional cost for our patients. But if the
Yeah.
patients do the monitoring regularly, then match check natin. Pero if yun nga, hindi siya mino-monitor regularly and you do not really see, kasi yun ang usual tanong ng prescriber sa ClinFar when they do recommendations for drug-drug interactions eh.
Mm-mm.
What is the chance that this particular interaction will manifest?
Oh
So,
man, that's like a pain to answer
yeah,
because
it's
like
very hard.
no matter what percent you give, if it's not zero, it can happen, right?
True. So, pero as yun nga, as a clinical pharmacist, you have to be prepared when when they ask that question. It's
Yeah.
a hard
So should I just
question.
answer? There is a non-zero chance. That's still technically true. The joke lang. Yeah,
Yep.
I think I get the reason for asking. Pero
Mhm.
syempre nakakakaba na no matter what percent you give, it can still happen talaga.
Yep. Mhm. It can possibly happen, partner. So yan, ano lang,
Right.
watch out for something to consider.
Yeah. Okay. So I think we've been talking on
Mhm.
long enough. Let's get to the final verdict.
Mhm.
Char, what's your ikaw talaga dapat muna, no?
Oo nga eh,
What's
ikaw
your ako
sa
dapat
next
mauna ba? Ako
episode,
na lang.
sige
Ako
ikaw
na
na
lang.
mauna.
Sige, para fair. Para di ako ma-influence sa rating mo.
Yep. Sige,
Um,
sige.
again, I'm transparent about this. I do not have really experience in emergency settings or like handling acute decompensated heart failure, things like
Mhm.
that.
Mhm.
Um, and I see a lot more of the maintenance meds and all.
Mhm.
Um, but so I guess like for everything you've talked about and like ano ba? I have bias. I have so many biases kasi, not
Mm.
financial biases, but more of like just in my head, like ideas of what I like, quote unquote, better.
Yep.
Um, like in terms of like heart failure, for instance, I
Mhm.
do like the meds that can long term save a person, increase a person's lifespan. For instance, survival, etc. As compared to looking at furosemide, it's kind of just a short term thing that I haven't really seen any robust changes in outcomes. Diba? It's like digoxin, no?
Mhm.
Diuretics and digoxin they don't really change outcomes significantly as compared to say ACE, ARBs.
Yep.
But of course, the fact that they're still being used and recommended for use means there's still a reason for using them. I just haven't looked into detail the outcomes they really do change. Cost wise, it's still pretty low naman. Lots of
Yep.
generics.
Mhm.
I'm a simple guy, really. So, yun lang. Efficacy, tolerability, cost, yun yung tinitingnan ko. Just, I can't form a solid opinion on this. So, I'm gonna put this at a 3 muna. Not because I dislike or like it, but because I
Mhm.
haven't seen it in action enough. So, this is just an on-paper rating to warrant
Mhm.
a solid rating of any sort in any direction. So,
Mhm.
kumbaga,
So
3
3.
asterisk, but the 3 will change in the future when I see it a lot more, siguro.
Mhm.
What about you?
Siguro for me partner, naalala ko yung rating ko kay Clonidine. Sabi ko parang ang taas ng rating ko nun. Pero well, anyway. For
Again, no pressure to change your standards. If those are your standards, right? Out of 5,
Yep.
what do you rate it?
Uh, for Furosemide, I think 4. I'm leaning towards
Okay.
a 4.
All
And
right.
number one, partner, I have to agree with the cost. It's used widely. I think the number one consideration for that is because of its cost and its
Okay.
availability. So
Okay.
you usually see nga ang daming ang daming brand name, sorry, na available, and then
You.
even the
You.
IV ones, no. So
Yuck. No to
you
brands tayo
know,
dito. Just.
yep, no to brand, so we won't be mentioning the brands, the innovator brands as well. So, yep, in terms of availability and cost, nasa higher up rating ko si Furosemide. Kasi yun yung
Mm,
reason niya ba't siya ginagamit. But yun nga partner, in terms of its overall picture sa pharmacotherapy ni patient, like putting into context like yung misconception about hypertension because of its
mm,
shorter duration of action, you can't really use that as a maintenance. So hopefully, after listening to this podcast, mawala na yung notion ng participants natin or ng listeners natin on that aspect.
mm,
And as well as other comorbidities siguro partner like heart failure and the kidney diseases that your patient would have. But in
mm.
terms of like giving this medication, naalala ko kasi may IV counterpart 'to. Yung mga past, I think yung mga past natin, naka-focus din tayo sa oral. But this one kasi,
Yeah,
I see it more clinically given
as
IV.
IV. Okay,
Yep.
so this is rating
So,
for both, regardless of what dosage form you're
yep.
giving it.
So, as a whole,
Yeah, as a
so
whole.
in terms of IV administration kasi it's very easy to administer. You see the ampule, you break it
Mm,
off. The nurses would usually aspirate it from the ampule and then it's kind of ready to be given to the patient. No more
okay.
frills, no more additional, it's already ready. So very
All
easy
right.
to administer. So I
All
think
right.
that's a good point to consider for me. Kaya ako siya
Mm,
binigyan ng 4 as well.
mm.
So yun
So
partner.
more
That's my
practical
4.
stuff, less of the clinical efficacy, tolerability. It's really more the
Mm.
practical stuff for you. All right.
Yep.
No, no,
Mhm.
that's fair. Yeah. Um. So, right. Wait.
Yay.
That was a bit more intense. Can we
Yeah.
pick a simpler? Can you pick a simpler med next time? Talking to
Guys,
you, audience.
yung medyo madali naman
Joke.
please, sumasakit na yung brain cells namin ni Jarvin, charot.
No, no, no. I mean, it's a fun challenge. It's fun. I'm just kidding. Like, yeah, go for it. We'll take whatever you can throw at us.
Yup, yup.
Yeah. So we within the options, it means we're game to talk about it naman, diba?
Yeah, yeah.
Um, we have to talk about the next poll options. I have actually no, I have an idea now.
Mhm.
I'll talk to you about the next poll options, and we can let our viewers decide the next drug for them to vote.
Okay.
But until next time, again, thanks for
Yeah.
tuning in.
Thank you
This
everyone.
is Once
Once
Daily
daily.
with Jarvin, and
Char. Thanks
yeah, so we'll catch you
everyone.
next week for the next episode, whatever that will be.
Yep.
Ciao.
Bye.